Welcome to today's webinar. My name is Jose Francisco, Project Manager at the IAS-USA. I'd like to introduce today's speaker, Dr. Asa Radix, who will be going over the management and prevention of HIV among transgender adults. Welcome, Dr. Radix.
Hi, thank you for having me to talk about this issue, this very important issue. So first I want to let you know that IAS-USA designates this live activity for a maximum of 1.5 CME credits. The webinar is also approved for 1.5 hours of nursing and pharmacy credits. Generous support for this activity has been received from the following contributors, and they're listed here. A separate, we'll be having some polling questions, and a separate window will show the poll questions. You're going to choose your response from the poll. Please don't put your responses in the chat box. And the responses will be displayed after the poll closes. So you can, if you have questions, those can go into the chat box. So the first poll will be here. What part of the US are you from? Why don't we see these results? Okay. Can we see the results from the first poll? Here we are. Good. Now we have a second poll, which is to rate your experience in the prevention or medical treatment of HIV infection, from novice to expert. Good, and it looks like we have a fair diversity of treatment experience here. Thank you. So I'll move to the next slide. So I wanted to start with just a few quick learning objectives for today's presentation. And first we're going to describe the epidemiology of HIV in transgender populations, and then also look at some of the multi-level factors that impact on the HIV and prevention care continua. We're going to be discussing quite a lot about hormone management today, and also looking at strategies to incorporate transcompetent healthcare into clinical practice. So I'm going to start with two pre-test questions. They're fairly long. And we'll be doing these again at the end. So first, you've diagnosed a 25-year-old transgender woman with anal chlamydia. You advise her to consider pre-exposure prophylaxis, or oral PrEP, with daily anthracycline and CDF to reduce her risk for HIV acquisition. She takes spironolactone 100 milligrams twice a day and estradiol 2 milligrams twice a day as part of her gender-affirming hormone therapy. At baseline, her tests reveal a negative HIV screening test. Hep B surface antigen is negative. Renal function is good. eGFR is 90. But she's concerned about the possibility of drug-drug interactions between her hormones and PrEP. Now, which of these statements is true regarding the use of PrEP among transgender women? PrEP has been demonstrated in clinical trials to be highly effective in preventing HIV acquisition among transgender women. B, PrEP is associated with a 10 to 15% reduction in estradiol levels. C, medical mistrust and previous experiences of discrimination are associated with low PrEP uptake. And D, feminizing hormones significantly reduce levels of tenofovir, and therefore PrEP should be avoided. Good. Okay, so the poll is closed. Looks like the majority of people picked A, followed by C. So can we do the next question? This is a 20-year-old transgender woman who comes to the clinic for STI screening after a partner was diagnosed with syphilis. She's been on a feminizing hormone regimen for 3 years on spironolactone and estradiol. You perform a rapid point-of-care HIV screen that is reactive. She's asymptomatic and is known to have no renal disease. So which statement is true regarding next steps? A, she's not a candidate for rapid initiation of ART because of her hormones. B, initiation of ART immediately is acceptable and associated with a shorter time to viral suppression and improved retention in care at 12 months. C, the use of gender-affirming hormone therapy is associated with reduced efficacy of ART. And D, initiation of ART should not be started until an HIV confirmatory test is done. Okay, looks like the majority of people picked B. So we'll see if your answers change at the end of today. So I'm moving to the next slide. So I wanted to start this presentation with a clinical case. It's not all that straightforward. So we have a 28-year-old transgender woman who presents with sudden onset of shortness of breath, cough, and chest pain for 3 days. She's had no viral prodrome. On exam, you can see she's normotensive, but has tachycardia and tachypnea. She's afebrile. She has a low oxygen saturation of 85%. And a chest X-ray is done that shows bilateral patchy infiltrates. So I want you to think about your differential. What are you thinking of when you see this woman coming in who is hypoxic and has an abnormal chest X-ray? And I should say that the HIV rapid test in the clinic is reactive. So think about next steps. So, you know, the differential diagnosis of pulmonary issues in a person with HIV is really quite broad and includes infections due to bacteria, including mycobacteria, fungi, viruses, parasitic infections, and, you know, other pathogens, as well as numerous non-infectious causes. And usually, you know, knowing the CD4 count and level of immunosuppression, you know, helps us in narrowing, you know, the differential down, but we don't have this information. This is a woman who has a, you know, she's newly diagnosed in the clinic. Now, all people living with HIV, regardless of CD4 count, are at increased risk of, you know, TB, community-acquired pneumonia, you know, histo, and non-Hodgkin's lymphoma. When we look at the infectious causes, though, many have a subacute onset. Her symptoms were fairly rapid onset. She also has significant hypoxia. So I think at the top of my list would be pneumocystis pneumonia. And I think currently I'd also now consider COVID-19, despite the fact that she had, you know, lack of fever. So a chest X-ray, a chest CT is done that shows diffuse infiltrates peripherally, as well as multiple soft tissue nodules in the breast. And on further history, the patient discloses that she had about a ½ liter of liquid silicone injected into both breasts 1 day prior to the onset of symptoms. Now, ultimately, a diagnosis was made of silicone embolization and pneumonitis due to silicone injection into the breast. And the use of silicone, I want to say, is, and other soft tissue fillers is fairly common in transgender people. About 17 to 50% of trans women inject fillers into their breasts and buttocks, and other substances, as you can see, you know, paraffin, cooking oil, super glue, mineral oil. There's even case reports of fixer-fat being used. You know, the rates are much higher among Latino women. And I want to, you know, the reason why I decided to start with this case about silicone pneumonitis was because all clinicians providing care to trans individuals should be aware of all the medical as well as non-medical interventions that transgender people may undertake. So hormone surgeries, soft tissue fillers, binding, tucking, and all of these can have important effects on health outcomes and need to be considered in the differential diagnosis. So to start this discussion on trans people, it's really important to think about the differences between sex and gender. So when we think about sex, we're thinking predominantly about anatomy, which decides how we are assigned at birth as either male or female. And into this comes the interplay of chromosomes and hormones. Now, gender identity, on the other hand, is how we define ourselves as male or female or something else. And children, I'll say, are often aware of gender categories at a very young age and can identify themselves, label themselves and other people correctly, usually by about age 3. And by age 4, they understand gender constancy or gender stability. So, you know, if you go to sleep as a boy, you're going to wake up as a boy. And in this presentation, I'm going to use many different terms. I think it's important to understand that language around gender identity is constantly changing. So you need to really stay up on the terminology. It's going to differ across cultures and also geographically. When I talk about people who identify as transgender, I mean anyone whose gender identity is different from the sex assigned at birth. We'll be talking about transgender women, so people who were assigned male at birth, but have a female or feminine gender identity, transgender men, those who were assigned female at birth with a male or masculine gender identity, and there are also people who identify as genderqueer, gender non-binary, gender diverse. You might have heard of gender non-conforming. So people who identify as something else, neither entirely male nor female, or perhaps a combination of both, or a different identity altogether. Cisgender, when I talk about cisgender people, I'm talking about people who are not transgender. So in other words, they identify in the same gender that they were assigned at birth. So we should also think about how many people identify as trans. You know, we estimate about 25 million people, well, 25 million adults worldwide. And this is really based on studies in the US and Europe showing that around 0.4 to 0.6% of adults identify as trans. In the US, that translates to between 1 and 1.4 million adults. We also have some data on youth from the Youth Risk Behavior Survey that indicates that almost 2% of high school students identify as trans or gender non-binary. And the last figure I want to give you is that about a third of trans people identify as non-binary. I think this is really important when you know, you have someone in front of you, not to make assumptions about how they identify themselves. So around the world, we're seeing more and more that trans people face extreme amounts of discrimination in society. And here are some figures from the US Trans Survey that was published about 5 years ago. So in the US, almost 2/3 of trans people have faced discrimination in the last year. And this includes high rates of sexual and physical assault, as well as mistreatment at work, housing discrimination, family rejection, bullying, which is really problematic for children who often will leave school or drop out, Most troubling, I think, is that a third had experienced healthcare discrimination, which includes denial of health services. And as a result of that, about 1 in 4 will avoid healthcare services altogether. And you can see here on the right, I have, the montages, just pictures of transgender women who were murdered in 2018. And you can see so far in 2020, just as of a few days ago, we've already had 28 murders of trans people in the United States. So when we think about trans-specific vulnerabilities to HIV, many of these are rooted in transphobia or the negative attitudes and beliefs that people have about trans people and that often result in discrimination. And as you can see here, there are structural and interpersonal as well as biologic and individual factors that increase vulnerability to HIV. These include high rates of violence, victimization, high prevalence of depression and suicidality, as well as substance use, high rates of sex work, which is often a result of exclusion from the workforce. And also mistreatment in medical services and medical settings especially are going to result in avoidance of medical care that includes opportunities for HIV screening, access to prevention services, STI diagnosis, treatment, engagement and retention in care, as you can see here. So there are limited data around the world that look at HIV prevalence in trans populations. This is mainly because in many countries, transgender women, the data for transgender women is included under MSM. Many of the data gaps, as you can see, are in low and middle income countries. The white spaces are the countries where no data are available. But we do have one meta-analysis that was done. It's quite some years ago, but they looked at 15 countries and estimated that the global prevalence of HIV was 19% among trans women and a 49-fold increased odds of HIV infection compared with non-transgender adults. And although there have been more data available since this paper was published in The Lancet, the global estimate of about 1 in 5 transgender women living with HIV is really about the same. We have another question here. What is the prevalence of HIV among transgender women in the United States? A, 8%, B, 14%, C, 30%, or D, 55%. Right, so it looks like about 50% of people chose C, 30%, and about a third chose B, 14%. The correct answer is 14%. So we know in the U.S. there are about 1 million people living with HIV, and the overall HIV prevalence is actually less than 0.4%. We do have data on transgender women living with HIV. The estimated HIV prevalence is about 14% in the U.S., so a little lower than the global estimates. Among Black and Latina trans women, the prevalence, though, is several-fold higher, as you can see, 44% among African American transgender women and about 26% among Hispanic or Latina trans women. In the U.S., transgender men have a lower prevalence of about 3.2%. Again, this is lab confirmed, but this is still much higher than the general population. So earlier this year, the CDC released the most recent HIV surveillance report, and this is really for the first time that it's included transgender people. And they found almost 10,000 transgender women living with HIV. And we think this is probably an underestimate because it really depends on different states and territories providing information on trans people. And you can see here when looking at age groups, about a quarter of transgender women are under age 24. So it really is quite a young population who are living with HIV. And this slide here is looking at transgender people with HIV by race and ethnicity, also from the same CDC HIV surveillance report. You can see here of the approximately 10,000 transgender women living with HIV, almost half were African American and about a third were Latina. And among transgender men, again, we're seeing the same in red, about half were African American. However, fewer were Latinx, and those who are white accounted for 23%. And this slide is looking at diagnoses of, new infections among transgender adults by age. And overall, new diagnoses of HIV in transgender people have steadily increased compared to previous years. The number of diagnoses for transgender people in ages, 25 to 34, 35 to 44, and 45 to 54 have increased over the last year, while the number of transgender adults aged 13 to 24 appears to have decreased. Now, when we look at global HIV incidence, we can see that it's quite high, internationally, with HIV incidence as high as 20 per 100 person years in Kenya. And even within countries, there are subpopulations which include, transgender women sex workers who have even higher risk for HIV infection. And I think this is important. It's important to look at these statistics because, WHO recommends pre-exposure prophylaxis for populations that they say substantial risk for HIV, which they define as an incidence over 3%. And similarly, the IAS-USA recommends PrEP be considered when the HIV incidence exceeds 2%. But you can see here that definitely for transgender women, PrEP should definitely be considered using either of those recommendations. And when people are diagnosed with HIV, it is important that they are engaged in care and initiated on ART. And these are data from the Ryan White HIV program showing the rates of viral suppression, showing rates of HIV viral suppression overall. You can see here is 87%, but among transgender women, it is lower at about 82%. So, it's about a 5 percentage points overall lower. But when you look at young people ages 20 to 24 and 25 to 29, as well as those who are unstably housed, the disparities are even greater. So one of the questions, of course, is, why is viral suppression lower among transgender people? And some of the reasons are listed below, and they include, it's quite a kind of diverse range of reasons, but prioritizing transition-related medical care over HIV care. So, if you have to see a different provider for your hormones and then another provider for your HIV care, and you have to decide, probably seeing the provider for your hormones is going to be more important. And we'll see how that plays into reasons why we should be thinking about co-locating services. But other reasons are, fears about drug interactions between hormones and HIV medications, negative experiences with providers which keep people out of health systems, fears of being discriminated against, HIV stigma, as well as the other issues that we talked about, higher rates of mental health issues and substance use, as well as unstable housing. And again, many of these are the results of transphobia and social exclusion. So, we have to intervene on multiple levels. There have been several studies that have investigated, how to improve the HIV care continuum for transgender women. And many of the studies actually were a result of a SPINS initiative that was funded by HRSA between 2012 and 2017. Some of the interventions that were found to improve HIV care outcomes included, integrating HIV care with hormones. It was found to be extremely important. Also, peer health navigation, and also contingency management. So, that refers to giving an incentive. For example, you can give a cash incentive for keeping appointments or achieving viral suppression, which is something we've done here in New York. I'll say that there are also additional studies that are underway. And I've included 3 here. So there's the Healthy Beavers. It's a randomized controlled trial that's looking at gender affirmation and healthcare empowerment versus standard of care. And of course, it's got primary outcomes of viral suppression. There's another which is Text Me Bill. It's also an RCT that's using text messages to improve engagement, retention, viral suppression, and a third one, which is the Alexis Project, which is using peer health navigation and contingency management. I mean, there are others, but we'll probably have the results from these 3 studies earlier than others that are underway. And I wanted to put this slide up. This is a slide from our experiences in New York City, and it's really showing why it's important to disaggregate data by population group when you're looking at HIV quality indicators. Now, in New York City, transgender women have always had a much lower rate of viral suppression compared to other groups. So we have here, compared to cisgender men and compared to cisgender women. Over the last few years, there have been quite a few investments into the trans community by the health department. So they've rolled out programs to educate medical providers. There have been numerous seminars, webinars. They've also improved publications directed towards the trans community and resource guides, other materials. And you can see here that over time, so between 2007 and 2016, the viral suppression rates for trans people have increased from 42% to 73%, which is really phenomenal, and a steeper rise than for any other group. But it really is important to, as I said, disaggregate the data, because trans people only account for maybe 1% of HIV infections. If you don't disaggregate, you don't actually see the disparities that exist. So I'm going to start with here with another case, just to illustrate a few points. So we have Mareka. She's a 32-year-old African-American transgender woman. She's recently moved. She's seeing a new provider to renew a hormone prescription, and she has no medical complaints. Her medical history: she's used gender-affirming hormones since she was 22. She's had no gender-affirming surgeries. She takes oral estradiol twice a day and spironolactone twice a day. Her sexual history: she has sex with cisgender men only. She's never had an STI. She's unaware of her HIV status. She's had a new boyfriend for about 3 months, and she says she uses condoms most of the time, almost always. As part of the routine exam, she receives a point-of-care HIV test, which is non-reactive, and then she has a full STI screen, so syphilis, gonorrhea, chlamydia, hepatitis screen, as well as routine labs for her hormone management. So she receives a call 2 days later. The STI screen is positive for anal chlamydia. So she's, counseled about HIV prevention and they discuss condoms. But just a few questions for all of you. First thing, is she a candidate for HIV PrEP, pre-exposure prophylaxis? What are some of the barriers and facilitators to PrEP care? Are they the same or different to barriers and facilitators to HIV care? And what should providers know about gender-affirming hormones? So which statement here is true regarding the use of PrEP in transgender people? A, transgender women are twice as likely to initiate PrEP compared to transgender men. The FDA has approved on-demand PrEP, also called 211, for use in transgender people. Transgender men should avoid PrEP due to the risk of acute kidney disease associated with testosterone use. And D, PrEP does not affect estradiol, estrone, or total or free testosterone levels in transgender men and women using hormones. Good. It looks like the majority have chosen D, and the PrEP does not affect estradiol, estrone, or other hormone levels in transgender men and women using hormones, which is actually the correct answer. Well done. So, as we're thinking about PrEP, it's important to think about the PrEP care continuum, which really does begin with HIV screening. So we should think about how are trans people doing as far as screening for HIV. And this slide shows data from the Behavioral Risk Factor Surveillance System, which, as you know, is a phone survey of the U.S. adult population. So, all these data are self-reported. The important thing to know is that gender identity was included, after 2014. Not all jurisdictions participate, but we're able to look at this and see how well folks are doing. But as you can see here, transgender individuals have lower rates of ever screening for HIV compared to cisgender MSM. Which I think is really important because, they're testing at much lower rates despite having higher rates of HIV risk. And in fact, the screening rates for transgender women is about the same as for cisgender heterosexual men and women. Really not enough. So, clearly the way to start is to improve screening rates. So one of the issues, and it was referenced in the ARS question, was about drug-drug interactions. So one of the concerns that's often raised by trans people, as well as by their providers, is about the possibility of drug-drug interactions between ART and hormones, especially feminizing regimens, so estrogens. And as you know, the first step in the metabolism of estrogens is hydroxylation in the liver using the cytochrome P450 enzymes. So this does raise the potential for drug-drug interactions with protease inhibitors and NNRTIs, which inhibit or induce some of the same CYP450 isoenzymes. So it does mean that some hormone levels may possibly be elevated or lowered depending on the type of antiretroviral therapy a person is receiving. If you want, the picture here didn't come out very clearly. It's actually from the HHS antiretroviral guidelines for adolescents and adults. So, this is important to know because in 2019 there was a new section that was published in the guidelines that are specifically for transgender people living with HIV. And it's really a good place to look for information on drug-drug interactions between gender-affirming hormones and ART. I also want to say that, it is important to recognize that there are no data that specifically examine interactions between the types of hormones that are used by transgender people, the types of estrogens, and HIV medications. Most of the data actually are extrapolated from what we know about oral contraceptive medications, and that's ethinyl estradiol, which is really not used in transgender populations anymore because of the risk of, venous thromboembolism, so DVTs and pulmonary emboli. But this is why I haven't provided, 30% change or 40% change, because we really don't know. So the antiretroviral agents that have the least potential to impact gender-affirming hormone therapy include, as you can see, the unboosted integrase inhibitors, rilpivirine and doravirine. Those are fairly safe to use. The good news is that, integrase inhibitors are already first line, so they're almost always going to be chosen for care. Now, boosted elvitegravir and protease inhibitors can increase testosterone levels, while ritonavir-boosted protease inhibitors, as well as efavirenz, etravirine, and nevirapine, can reduce estradiol levels. So this is also important to know. Now, the effects of cobicistat-boosted regimens on estradiol aren't clear. So what do you do with this information? Again, every protease inhibitor is going to have a slightly different effect. So if you're using boosted proteases, what we recommend is that if you have a person on feminizing hormones or on testosterone, that you just measure the hormone levels after they've been on their ART. And if you see the levels have dropped or are elevated, then you just adjust the hormones. And we'll be talking quite a lot about hormones at the end of this presentation. But really, you don't need to be concerned, and it's best just to let your patients, let your clients know that you'll be measuring hormone levels, you'll be able to see if there are changes, and that you'll make adjustments as needed. And there's absolutely no reason not to take their ART for treatment or for prevention. Now you can see here that the NRTIs aren't on the list, and that's really because NRTIs are renally excreted. We really didn't think there was going to be any type of interaction with estrogen, which is metabolized through the liver. But I wanted just to talk about some of the PrEP studies and some of the issues that were raised there. Now, when PrEP was approved for use, there was only one clinical trial, which was the IPREC study, that included transgender women. And the first publication that came out from that study reported that there were only 29 transgender women, so about 1% of participants were trans. But a later sub-analysis that was led by Dr. Deutsch at UCSF identified additional trans women, including people who hadn't identified as trans but were taking estrogen. And this increased the number of trans women to overall to about 339, or 14%. So among transgender women, and these are the results, unlike in cisgender men, it initially appeared that PrEP was not effective because the hazards ratio was 1. So the number of seroconversions were the same in people who were on PrEP and not on PrEP. But when they examined the data further, they realized that women had extremely low adherence to PrEP. And the most important takeaway, though, was that for, women who were assigned to the PrEP, those who seroconverted had no drug detected in their blood. So it wasn't a matter that the PrEP didn't work. It was the fact that they weren't taking it. But for women who had levels consistent with taking more than 4 pills a week, there were no seroconversions noted. So the question was, of course, is it all about adherence being lower, or possibly could there be some type of drug-drug interaction between either tenofovir or emtricitabine with the feminizing regimen? Subsequently, there have been other analyses that showed that really baseline characteristics explain many of the differences that we're seeing. But still, when this sub-analysis came out, there was a lot of attention that was paid to trying to figure out really what was going on. So, there were a few pharmacokinetic studies that were done looking to see whether or not there were drug-drug interactions. So the one study here, which was the IFAC study, this was conducted in Thailand by the Thai Red Cross. They looked at interactions between oral PrEP and estrogens among just 20 transgender women. They found that estradiol levels were not affected by PrEP, which is good news for our patients. But they did see that tenofovir exposure seemed to be reduced by about 12% in the presence of feminizing hormones. A second case study was done in North Carolina. This is the study by Mackenzie Cottrell. And here they found, and this was also a small study, they looked at interactions in just 8 transgender women, and this was a North Carolina study, looked at plasma and rectal tissue concentrations of tenofovir in 4 transgender women, 4 cisgender men, and 4 cisgender women. And they found that blood and rectal tissue levels of tenofovir were similar, but there seemed to be a lower ratio of tenofovir diphosphate and DATP in rectal tissue. And again, it's unclear what that means. Now, for the last study also looked at interactions in 8 transgender women and 8 cisgender men and found about a 24% reduction in plasma tenofovir levels. So, the data were a little confusing. The studies were small. I think the main takeaways were that estrogen levels do not change. Again, that's really important for our patients. Serum tenofovir may be modestly reduced in the presence of estrogen, but the clinical significance wasn't known because, the levels should still have been therapeutic, the levels of tenofovir. There were suggestions from this that transgender women who were on hormones may need greater adherence to PrEP, and, the results of interactions on on-demand PrEP were studied. So there was a lot of concern, but, the studies, again, were fairly small. During the AIDS conference, we were delighted to see the results from the iBreed study, which was a pharmacokinetics sub-study of the TRIUMPH project. And the TRIUMPH project was a community-led PrEP demonstration project in trans populations. So really the first one that had been done, and 1 of 3. And the goal of the iBreed study was to investigate drug-drug interactions between PrEP and estrogens and androgen blockers in transgender women and testosterone in transgender men. So again, it was the first time that we had looked at whether or not there were changes or interactions between testosterone and the medications in PrEP. So the investigators enrolled 24 transgender men and 24 transgender women who were on hormones. They received daily oral PrEP for 4 weeks. That was directly observed by video, or they were seen taking their PrEP in person. And then they measured hormone levels, looking at serum, and looked at tenofovir diphosphate levels using dried blood spots. And people were monitored weekly for 4 weeks. So that was the study design. Now, the results were quite interesting. They found that serum hormone levels, including estradiol, estrone, total and free testosterone, and DHT, as well as sex hormone binding globulin, were not affected by oral PrEP. And that's similar to what's been seen, as you remember, in the other PK studies. And these two figures demonstrate the estradiol at week 1 and week 1 and week 4. And the second here is looking at the plasma testosterone, again at week 1 and week 4. And you can see here that the estradiol levels and testosterone levels really aren't changing in the two populations. So the primary aim was to examine whether tenofovir diphosphate levels were lower. And they found that after 4 weeks on oral PrEP, cisgender men, transgender women, and transgender men had comparable tenofovir diphosphate in dried blood spot. And they were using historical controls for cisgender men. Also that all participants were projected to achieve highly protective concentrations. So I think this was excellent news. Again, this was a study that was specifically designed to look at this issue in transgender populations, and the numbers were, several times higher than had been in any of the previous PK studies. So going on to the PrEP, PrEP care continuum. So we don't have very good data on PrEP care continuum for trans people. So I was going to just present some data from the LITE study, which is a multi-site study that my clinic is part of. So this is a cohort of HIV negative transgender women who are being enrolled from 6 cities. And so visits include a baseline HIV, an STI test, and then ongoing testing every 3 months. And there's a phone app that folks use, and they complete surveys on that. You can see the surveys, and then they do a home HIV test kit. So, these data were presented last year at CROI when we had about 1,100 women who had enrolled. So of those who were sexually active, 82% had heard of PrEP, which is quite high, but also these were folks who are engaged in care at clinics. So I think that's not too surprising. But only 23% had ever taken it. Only 13% had taken PrEP in the last month, and only 9% had been adherent to PrEP in the last week. So those, these data were quite disappointing, seeing the fairly low persistence on PrEP. For transgender men, we actually have 2 recent studies. I'm showing one by Sari Reisner and this one by Sarit Golem, and I'm showing the results from Sarit's study here. This was a study that enrolled about 1,800 transgender men in the United States. Almost a quarter of them met 1 or more criteria for PrEP. However, few had received PrEP information from their provider. And as you can see here, at the end, only 11% had access PrEP, showing that gaps also exist for transgender men. So moving on to the next ARS question. So transgender women at risk for HIV are less likely to receive PrEP than transgender men. And what are some of the reasons for, cisgender men, what are some of the reasons for this disparity? A, worried about interactions with hormone therapy. B, mistrust of providers and researchers. C, low HIV risk perception. D, lack trans-inclusive marketing, and E, all of the above. This is an easier question, I think. Okay, so about the majority have chosen all of the above, which is the correct answer. So what are the reasons for a low uptake in PrEP for trans people? You know, there have been several studies that have looked at some of the key barriers, and we mentioned many of those in the ARS question. They include lack of knowledge, although knowledge has been higher in recent studies, but also mistrust of providers and researchers, concerns about side effects, low HIV risk perception, HIV stigma, lack of trans-inclusive marketing. Although it's improved, you can see here on the right one of the New York City Play Sure ads that's in the subway that include people of trans experience in the marketing, and also, again, concerns about hormone interactions. I think it's important when you sit down with clients that you're addressing all of these issues. You know, it's really important to engage people in HIV prevention. You can see here some of the facilitators, trans-competent services, prescribing hormones at the clinic. So really some of the similar things that we're seeing to improve HIV care, having materials, health promotion information, recommendations by a trusted medical provider, and also that the provider facilitates getting PrEP. So, for many trans people who may be underinsured or uninsured, it's really important to link people to either insurance or to, the medication assistance programs. Again, get them information and talk about the lack of interactions between PrEP and hormones. Again, that's fairly important for most people. So I want you to think about the last time that you went into a medical clinic. And, how did that interaction go? What happened when you went up to the desk? And no doubt for many of you, the first thing that happened was, I need a copy of your ID and here's a form to fill out, right? It seems pretty straightforward, but you can imagine for trans people, many of whom may have an ID card that doesn't match the name that they use, doesn't have a sex marker on it that reflects who they are. These interactions can be extremely uncomfortable. When people are identified as trans, sometimes at the front desk, sometimes the reactions can be, quite negative. If they're given a form to fill out that has a box check M or check F, sometimes it can be confusing, like what do I check? Do I check who I am, or do I check what's on my ID card or my insurance card? If you haven't had your gender markers changed. So one of the issues that one of the things that we do in our clinic and that's recommended is that you ask a two-step question, which is a current gender identity as well as sex assigned at birth. So some transgender women may not identify as trans, they just identify as women, but it's necessary to know, how they identify, but you do need to know sex assigned at birth so you can provide correct, preventive care, right? So I need to know if you have a prostate. I need to know if I should be doing cervical screening. I need to know, whatever preventive care is sex-specific, I need to know that because that's going to be according to your sex assigned at birth. So that's the first recommendation, obviously, to have inclusive forms when people enter the clinic, and forms that are going to help you provide the correct level of care. I should also add that, gender-affirming care actually starts before you even interact with the clinic. You have to usually call the clinic to make an appointment. And, it can be really disturbing when you call the clinic and the first thing the call center says or the receptionist says is yes, ma'am, or yes, sir, based on your voice, and understanding that many transgender women who've transitioned later in life will have a deeper voice and will often be mistaken for men on the phone. So, and once you hear that, once you're misgendered on the phone, it's very easy to never want to interact with that health center again. So again, start even before people come into the clinic. So using chosen names and pronouns, looking at the environment. Do you have information that transgender people are looking for, or images? Are your restrooms gender neutral or gender inclusive? Do you have single stalls that can be used for that? Do you have staff who are trans-identified? Do you have non-discrimination policies? And again, probably most important, are your providers able and willing to provide prescribed gender-affirming hormones? So, it's kind of a checklist that you can do, and a lot of this information is available from the Human Rights Campaign website and others. So I was asked to talk a little bit about gender affirmation or, transition for transgender people, based on, I guess, a survey that had been done to people accessing these webinars. Providers often only consider medical transition, so hormones and surgeries, but it is really important to understand that, gender affirmation also includes social, legal, and, psychological components. So people may change their name and pronouns and nothing else. Or they may take hormones and decide not to do surgeries. Or they may have surgeries but not want to do hormones. So it really, you should think about this as an individualized approach, and, it's about meeting patients' expectations and goals. Not everyone wants to have a medical intervention. So as far as medical transition goes, because we're all medical providers, mainly we're talking about introduction of hormones, so testosterone for trans-masculine folks, so transgender men, estrogen and androgen blockers for transgender women. And I should also say for non-binary people can also access hormones. It's all about what their goals are. The other things that are on the list include top surgeries, so either mastectomy for transgender men or breast augmentation for transgender women. We have a whole list of bottom surgeries. These are usually genital surgeries and include everything from metoidioplasty or phalloplasty to vaginoplasty. So vaginoplasty is creation of a vagina. Other things also fall under, medical transition. So voice therapy, hair removal, so electrolysis or laser, as well as prosthetics. So, you should be fairly familiar with all of these strategies for transition. So the other thing is that providers often contact me and say, I have a patient, my patient is a transgender woman. and who wants hormones, and I don't think that I'm qualified, and should I be sending this person to an endocrinologist, or can you see them? Because I don't know what to do. I don't know how to assess them, I don't know how to treat them, and what tools do I need? So I would say it's actually quite straightforward. The first part about assessment, it's important to remember that gender is determined by the patient, so you don't need to do any special tests. I mean, if they tell you they're a woman or they tell you they're a man, that's who they are. So that's, hopefully we've covered the assessment. It's important to find out about, the past history and, coming to terms with their gender identity, but, that's useful to know. But the main takeaway is that the patient determines their gender. The second is that primary care providers and HIV specialists are completely qualified to prescribe and monitor hormones. You've been doing this all the time. You've been giving cisgender women birth control pills. You've been giving, possibly you've given postmenopausal cisgender women hormones. You've given hypogonadal cisgender men testosterone. So you know how to do this. You know how to write the prescription. I would say that the necessary skills are really that you should be knowledgeable about gender identities and their diversity. You should have some familiarity with hormone regimens and guidelines, which we're going to discuss. You should also know about preventive care, especially after people have had started on hormones or have had surgical interventions. For example, a transgender woman who's been on hormones for more than 5 years, who is 50 years old, should have breast cancer screening, right? So those are some of the things you need to know. You should also understand a little bit about the mechanics of the surgeries and post-op management. For people who really want to get a higher level of, qualification or certification, you can get certified through the World Professional Association of Transgender Health that has a GEI, Global Education Initiative Certificate. You can do that, but it's not necessary. But for some people who like to have the backing of a piece of paper or certification, you can certainly do that. I also wanted to show you how many hormone protocols exist that give guidance on hormone care. In the U.S., I would say that the ones we use the most are the Endocrine Society here, published in 2017. There's also the Center of Excellence for Transgender Health that has primary care guidelines. And probably the one that's quoted the most, especially by insurance companies, is the World Professional Association of Transgender Health that has their standards of care. And this was published in 2011. The standards of care 8 is coming out next year. So definitely keep your eyes open for that. They're also all open access, so again, it's fairly easy to get access to those. So one of the questions I'm often asked is, what initial assessment do I need to do before starting hormones? You need to get a detailed medical history. You want to make sure that there are no relative contraindications to hormone therapy, and that would include, an active DVT or, PE. I mean, you probably wouldn't want to start estrogen in someone who is in the ICU with a PE, or untreated hormonally active cancer. So, it's really with this, you should have this multidisciplinary approach with the oncologist and with, the primary care provider trying to figure out, what to do with hormones. But, I would say it's okay to defer someone with active cardiovascular disease who's just had an MI. You probably want to weigh the pros and cons of hormones in that moment. But, these are all relative contraindications, meaning that once someone is stabilized, you can certainly go ahead and prescribe. It's important to know about other medications someone takes. You want to know about their past or current history of hormone use and how these were obtained. So did they get them from a licensed prescriber, or did they, were they self-treating, getting hormones over the internet or from friends? You also want to know about surgical treatment. So what gender-affirming surgeries have they had? What organs have been removed? So we say do an organ inventory. So do you have testes? Do you have ovaries? Do you have a vagina? Do you have a uterus? All of these are important, again, because you want to know how to provide the best preventive care. Asking people about, getting a social occupational history. We do this in all patients, and just being mindful that, for some people it may be difficult to disclose that they're sex workers, especially if they perceive that you have a negative attitude. So you need to work on facial expressions and ask the questions. I usually say, a lot of the patients I see, exchange sex for money or housing. There are different ways you can say this, but I think it's important to know. Also, so you can provide help as far as information about keeping safe, what to do if problems come up. It's like any other occupation. Asking people about tobacco use, especially extremely high rates of smoking in transgender populations, alcohol and substance use, family history, of course, focusing on cardiovascular disease and cancer, sexual health, who people are having sex with, what types of sex they're having. People have a diversity of sexual partners. They may have partners who are cisgender men, cisgender women, transgender men, transgender women, gender non-binary folk, and I think it's don't make assumptions and try to get a detailed history. Okay, and also whether someone has seen a therapist and what for. Any history of suicidality, depression, anxiety. Many of these issues will get much better once someone starts on hormone therapy. So there's a very easy general approach to hormone management. Mainly you want to recreate the hormone environment that's aligned with a person's gender identity and goals of care. Not everyone, everyone has something a little different. I have people say to me, I want to go on testosterone because I want my periods to stop, but I don't really want to get a lot of facial hair. What I usually say to people is, you can't really predict the results that you're going to get on testosterone, but we start off with low doses. We go slowly. We titrate the doses up as tolerated, and we have maximum doses, right? And you'll see. So we don't exceed usually the maximum doses unless there's a good reason. And then after that, it's really monitoring hormone levels and response to treatment. So again, these are general guidelines, and we do have, the Endocrine Society, again, UCSF and WPATH will all help to explain, how to adjust medications, how to approach people. So this is like the usual feminizing regimen that you'll see. Estradiol, oral estradiol is probably the most commonly prescribed medication, I would think, in medical settings. So we start off at a low dose. So I have here 2 milligrams a day. Some people start off even lower at 1 milligram a day. I think, again, you have to talk to patients about goals. It depends on other medical issues someone might have, their age. We usually use lower doses with folks who are older, for example. But say you're starting at 2 milligrams a day. The average dose is 4 milligrams a day. So if you start at 2 milligrams a day and the person is doing great, no problems whatsoever, you know, you can probably just go ahead and increase the 4 milligrams in a month or so. Some people would check hormone levels before making that change, but again, it's fairly straightforward. We also have other types of estrogen. We have injectable estrogen, estradiol valerate or cypionate. I've given the doses here for estradiol valerate. We have estradiol patches. We prefer patches in people with cardiovascular issues, heavy smokers, people who are older, you know, higher risk for cardiovascular disease, history of, you know, stroke and so forth. So you have, you know, pick an estrogen. If it's well tolerated, you can generally stick with that. Some people ask me, well, can I use more than one estrogen? I mean, there's usually no reason to. So try and stick with one, and it'll make it easier to make adjustments. Along with estrogen, for transgender women who still have testes, you're going to need an androgen blocker. This is usually, in the U.S., we use spironolactone for the most part. Start off low. You know, I start off at 25 to 50 milligrams a day, and then I titrate up. Generally, most women can be on 100 to 150 milligrams a day, but you're titrating up and you're checking labs. So I'll show you the labs you're looking for, but generally you want to see a reduction in the testosterone levels, total testosterone levels. You can also use finasteride, which helps with, you know, pre-existing androgenetic hair loss. Suppression acetate is not available in the U.S., but it is available in Canada and Mexico, so you may see patients on it. For people who are not able to tolerate the other blockers, you can use GnRH analogs like leuprolide. And, you know, again, there are guidelines showing you how to use those. So what happens with feminizing regimens? You get, you know, breast development, body fat changes, so you get hips, reduced muscle mass, reduced stamina, reduced erectile function, and reduced size of testes. For some, you know, most of these are positive effects for most trans women, but you will see adverse effects. So lower sperm counts, erectile dysfunction, gallbladder disease, higher rates of DVTs, rare prolactinoma rates, also hypertension. For transgender men, I think most people have been quite used to prescribing testosterone. You generally do the same thing for transgender men, so testosterone starting off at low dose, either injection, transdermal patch, and titrating up depending on levels. And masculinizing regimens, you know, you'll get increase in facial hair, again, redistribution of body fat, the voice will deepen, the periods will stop, and the clitoris will enlarge. There are some adverse effects: acne, increase in red cells, atrophic vaginitis, low fertility, baldness, pelvic pain, transaminitis that you will be keeping an eye on. So when people start on gender-affirming care, it has many positive effects. And I just want to highlight a few of those: improved quality of life, improved social functioning, reduction in gender dysphoria, but all, gender affirmation, so including using chosen name and pronoun has been a positive benefit. And for this presentation, definitely improving engagement in medical care and improving viral suppression. So lab monitoring is very important. You're going to evaluate the patient every 3 months in the first year, and then 1 to 2 times per year after that. You're going to measure serum testosterone, estradiol, LITE, prolactin level annually. For transgender women, really the testosterone level should be low, and the serum estradiol level should not exceed 200. So for transgender men, you're going to be targeting a testosterone level of 400 to 700. A few other changes that are really important for people living with HIV. You can see here an increase in triglycerides is noted, although we don't generally see a change in other lipid parameters. Other areas, again, that are important for feminizing therapy, you'll see an increase in weight, an increase in visceral fat, a decrease in insulin sensitivity, and a decrease in creatinine. These are all things to just be aware of as you're monitoring labs. Again, not a reason to not give people hormones. Some of the other concerns that are important: increased rates of DVT and PE that we've already mentioned. Usually this is associated with other factors like smoking. In the early days, they used to use ethanol estradiol or birth control pills, and that had a much, much higher risk. Other things, we see a higher rate of ischemic stroke. And again, in these situations, I would tend to use, in older folks or folks at high risk, use transdermal estrogen. Bone health is important for everybody, but very important for transgender people, especially those who've had donidectomy and stopped their hormones. And you can see guidelines for monitoring in the Endocrine Society guidelines. And just to finish up, there are other questions that we have. For example, what gender do we use in risk calculators that you have to put sex in? For example, cardiovascular risk calculators, FRAX scores for osteoporosis or for renal function. Generally it depends, right? How long has someone been on hormones? Usually I run parameters, I run them with both F and M, and then figure it somewhere in between. For bone health, they generally suggest using sex assigned at birth. Other questions, what is the impact of estrogen on HIV transmission and disease progression? There are some studies that show increased expression of certain chemokine receptors like CCR5. And I would say now, there are many questions about COVID-19. So, how are trans populations who are generally, not as maybe don't have the finances, how are they able to access telehealth? How are they accessing hormones or HIV testing if they have to go to somewhere other than their trusted provider? And what are the effects of hormones and spiral on disease transmission and severity? There have been a few publications asking these questions, and so far we don't have good answers. Just to finish up, I wanted to show you some PrEP resources that are available. Act Against AIDS from CDC. There are HIV screening information available. Again, a lot of this is from CDC. You can get posters. Here's some brochures that are also available, and we have a resource page. You can access some of this. So just lastly, take-home messages. We spoke about structural, interpersonal, individual, and biologic factors that increase HIV risk. We discussed that the gender-affirming care is an essential component of PrEP and HIV care, and also that medical providers should be really knowledgeable about transgender care guidelines and should be able to manage hormone regimens as well. And here's the resources on here. Post-test question 1. You diagnose a 25-year-old transgender woman with anal chlamydia. You advise her to consider pre-exposure prophylaxis. She takes Spiro and estradiol. At baseline, her test reveals she's HIV negative, Hep B surface antigen negative, and has a good GFR. She's concerned about the possibility of drug-drug interactions. Which statement is true? A, PrEP is being demonstrated to be highly effective in clinical trials to prevent HIV acquisition. PrEP is associated with a 10 to 15% reduction in estradiol levels. Medical mistrust and previous experiences of discrimination are associated with low PrEP uptake, and feminizing hormones significantly reduce levels of tenofovir, and PrEP should be avoided. That is the okay. So we have the correct answer is C, and we have about a 50-50 between A and C on this post-test question. And post-test 2, 20-year-old transgender woman comes in for STI screening after a sexual partner was diagnosed with syphilis. We perform a rapid point-of-care screen that's reactive. She's asymptomatic. Which statement is true? She's not a candidate for rapid initiation of ART because of hormones. Initiation of ART is acceptable. Use of gender-affirming hormone therapy is associated with reduced efficacy of ART, and initiation of ART should not be started until confirmatory testing is done. Good. We've ended the poll. About 80% have chosen the correct answer, which is that initiation of ART immediately is acceptable. There's no reason not to do rapid initiation of ART in someone of trans experience. So the next, I think we have a lot of questions, which is good, and I'm hoping I'll be able to see some of these. And I believe that some are going to be highlighted. Let's see. I think I can just start with the top here. The one question was, can you recommend a textbook and or training program on transgender health that includes initiating and measuring success? Yes, in the resources there are some, but definitely I would suggest reading the Endocrine Society guidelines and looking at the WPATH, WPATH.org has trainings around the country, both webinar-based, virtual and live. And as I said, they do have a training, but there are many trainings available, for example, on the Fenway site. The next question, what are the estradiol does lower levels of tenofovir found in plasma, correct? Well, I think the latest study from the iBreathe, the iBreathe study that was presented at ACE 2020 would say no, even though we had an initial small PK study, it doesn't seem like that held out in a larger study that was done. So I think we still need to see further data in that area. But regardless, the level of reduction in tenofovir does not affect efficacy because it's still well within a range that it's highly effective. What are the rates of obesity in transgender women compared to the population at large? And is this affecting your ART choice, knowing what we've discovered about integrase inhibitors? The rates of obesity are higher in transgender women compared to the population at large, I'll say. I don't have specific rates. It doesn't affect my choice of ART. I still use integrase inhibitors. I'm tasked when I need to. I think you should counsel clients about healthy weight. And also for many transgender women, putting on weight and having curves is something that they enjoy. So sometimes it's also about talking about healthy diet. That's a good question. Let's see. The rates of tenofovir and testosterone in trans women and trans men were covered in the iBreathe study. And actually, what was interesting is they measured estrogen levels and testosterone levels in both transgender women on estrogen and transgender men on testosterone. So they were able to look at both intrinsic and extrinsic hormones, and they did not change. So that's an excellent question. Please suggest contact for plastic surgeons in the New York, New Jersey